Hello, everybody. I see folks getting back on. It's funny how that number changes. All right. So it's officially it's 7 Eastern, but I'm in Scottsdale, so I have to remember it's 5 o'clock here. Good evening, everybody. Thank you for joining. We're excited to have you. We'll just give everybody just another minute. And while you're logging in, I would love to see where everyone is joining us from. I'll tell you this, Sally. It's a 26% humidity. You know, I live in South Florida, right?
Yeah,
So
yeah, yeah.
my eyeballs and my nostrils cannot take this. I
Mm.
love Scottsdale. It's beautiful, but like I have never had such like wacky eye and like nostril issues.
You would
So,
adapt. You would adapt. You
like,
do. You get very used to the low humidity. It's
oh,
awesome.
Southwest Florida, nice.
Southwest Florida. I
Nice.
mean,
Alaska.
Fairbanks.
What?
That's awesome. I did a locums
Misogyny.
there like 10 years ago or something. I just, wanted to go to Alaska. So I did a locum tenens at an urgent care in Fairbanks
Oh,
for
really?
like the months of August and September or something. Yeah, it was
How
awesome.
fantastic. In Virginia,
hmm
Roanoke. Very cool. All right, awesome. Well, we'll go ahead and get started. This topic, I love doing out all the topics with Sally, quite honestly, having these conversations. But this one is a great one for me because I'm an RN. I'm an RN, and it is really interesting for me to understand these differences, right? Like I'm an RN that works in this amazing NP world. But I know very well that what I do and what PNs, APRNs do are very, very different, right? So this topic is a good topic, and I'm going to start with $1 million question. Ready? What is the difference, right? What's the difference, the core responsibility, and this is what we're going to dig into between a nurse practitioner and an RN? Why is that such a hard thing? One thing I want you to think about too, that Dr. Fitzgerald always says, she says, the most smartest, the most brilliant RN could never pass an NP certification exam. The scope, the roles, the responsibilities are so, so different. And we know that like on a like high level, but really like help us dig into this when we're talking about these roles.
I'm sure that's true, but it I'm sure it is true because it is a different role.
It
It's like
is.
you can absolutely brilliant mathematician take a biology exam and not do well.
Right.
But before I answer, I'm going to say I see a shout out from Pensacola there.
Nice.
In another life, over 40 years ago, I was stationed in Pensacola, Florida, as a brand new United States Marine right out of boot camp. And I went to school in Pensacola to learn my military occupational specialty of cryptology.
Oh,
Cryptology, yes. I was a cryptologist, which sounds, oh, we thought it was going to be like, a fedora and top secret and being all like, a trench coat and stuff. But what it was intercepting communist communications
oh my
like by
gosh.
radio. So I had to go to Pensacola, and I spent the first 16 weeks learning Morse code. Da 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 did it da did it
You
da
still
da
remember
did
that?
it. Oh, I mean, I did it for like 10 hours a day, every day for 16
Wow,
weeks.
that's so
I
cool.
can't copy it as fast as I used to, but I would still remember it. But anyway, that has nothing to do with nothing. But when I saw Pensacola, had those memories. So, and Northeast Ohio, my sister was a Cleveland police officer for all of her adult life. Uh-huh. And
Wow.
so all of these and Fairbanks, I did my locum. So and I have relatives in Virginia. All these locations
Great to see
mean
everybody.
something to me. And even Indiana, I have people in Indiana. Actually have an ex-boyfriend in Indiana. So, anyways, back to your question. What was your the difference between an RN and APRN? Okay, so first the similarity is that we are all nurses, and it is important not to forget that. We are advanced practice registered nurses. So it's
Yeah.
really important not to forget that the common theme there is nursing. But the difference in advanced practice, I mean, it depends on who you ask. If you ask like an academic, like yours truly, those of us that teach it, an advanced practice registered nurse is a nurse with advanced skills across the continuum, across all the roles. We don't just practice at a higher level at the bedside, but although we do, the different level at the bedside is what everybody thinks of. And the key difference there is that we are trained and educated to make a medical diagnosis and develop a plan of care. And that's the real difference between, from a patient care perspective, from the bedside, the APRN and the registered nurse. APRNs are trained, educated, and licensed to make a medical diagnosis and prescribe a medical plan of care, and registered nurses are not. And so, I mean, that's the obvious one.
Right.
That's the big thing. And it really is a different way of thinking. It's so interesting because I teach nurse practitioner students at Drexel, and I teach pharmacology and physiology for the most part. But in both classes, one of the exercises they have is that they're given a patient case from start to finish. I give them a case, and then they have to answer a series of questions from the perspective of pharmacology or physiology, depending on the class. But in pharmacology, for instance, they're given a case, they're given a history, they're given a list of medicines, they're given some lab values, and then they're told, okay, this patient just landed in your office as a new patient. They moved in from out of state, going to run out of their medications tomorrow, and they need refills. You don't have any records yet. All you have is what the patient tells you, which, is not a whole lot sometimes. Like when you say, why do you take this pill? And they say, because, oh, somebody prescribed it, you know, it's all very real world. And so the exercises are the first question, they have to take each medication the patient is on and identify from the info provided the diagnosis for which they take it, either stated or inferred.
Got
Like
it.
this semester, there was a stated diagnosis of dyslipidemia. So the statin is for the dyslipidemia, and they have to identify that. But they're also on, I forget, lisinopril or something, and there's no stated diagnosis of hypertension, but the blood pressure in the scenario is 158 over 100. So they have, they look through the list and go, okay, we use lisinopril for CHF and for hypertension. It's probably for hypertension for this patient. They have to analyze that. You'd be stunned how many don't do it appropriately because they don't think that way. In bedside nursing, you don't think that way. So, like, I have this list of meds, and then the diagnosis I'll get will be things like high cholesterol, or something else is for the like the heartburn, and I get these kind of answers, even though they've been told to identify a diagnosis. And it's, I mean, I know that it's early in their education and they're still learning, but one of the utilities of that exercise is for them to see the difference in the thought process.
Yeah.
You know, how you
Yeah.
think, like at the advanced practice level, when you prescribe a medication, you have to be able to, in clear, unambiguous terms, identify the diagnosis for which you are prescribing it.
Yeah.
So like as they go through this exercise, question one is pick what you think is the diagnosis for the drug. The second question is it appropriate? Is it appropriate? Because some people will come to you on things that aren't appropriate for what they have.
Mm-hmm.
The third question is the big one. What will you discharge them on today? Write it like a prescription. And then the last question is identify one most important patient education item about this med. And in this exercise, it's so plain to me to see the difference in the thought process from the bedside RN to the APRN, and just like the precision in the thought process, and um, like there will be, when I ask them to make a list of meds they're going to discharge the patient with, some of them are changing everything. Some of them are putting in meds for some history that didn't even require it because they're not having problems now.
Yeah.
It's a whole different thought process. And so I guess I'm getting off on a little bit of a tangent here, but one of the biggest differences between the bedside RN and the bedside APRN, or the exam room side APRN, really is that very deductive diagnostic decision making skill set in seeing a chief complaint, moving through a history of present illness that is designed exclusively to figure out what's wrong, what's causing the chief complaint, and it's got to be focused and narrowed. And then you do a physical exam to support or refute it, and then identify the appropriate plan of care, which might include a med or might not. But there'll always be some plan of care, even if it's, educate the patient, benign, self-limiting,
Some
return, if no better. And it really is a different way of thinking.
It is very different way. And folks, I forgot
Hmm.
to mention, as we're speaking, go ahead and if you have questions, drop them in the chat, drop them in the Q&A. We'll answer all of those in the last like 10 or 15 minutes. So with that said, that big difference, you know, what would you say, like me as an RN, and if I was transitioning to an NP, talking about like these skills and knowledge, what are those that are really, really essential to help that transition over that you really want to make sure that you're sharpen and you hone in on in order to successfully practice as an APRN?
There's a couple things. And before we leave the last question, though, I started out with this and I got off on my own ADD tangent.
You're
Being an
fine.
advanced practice registered nurse isn't exclusively about the diagnostic reasoning, although that's a big thing, but
Yeah,
also in an academic world, the higher the level of preparation of the nurse, the broader their scope. Like the BSN really is educated and taught about managing the patient. So like with the example of vaccines, it would be about patient education.
yeah,
If you have a patient, you say, we do for flu shot this year and a COVID vaccine, and oh, you haven't had a Tdap in 10 years. It's about providing education to the patient,
yeah,
managing the patient. The master's prepared nurse, it's really about the community or the bigger picture of care, not just the bedside, but promoting health of the community as a whole. So about how can we contribute to making vaccines available and accessible to our populations, whether it's your local community or a certain age demographic or pregnant women, like providing information. Lots of pregnant women are scared to be injected with something when they're pregnant. And yet there are a number of vaccines that are not live virus vaccines. They will not harm the fetus. They will protect the mother, which in turn protects the fetus. And some of them actually confer some protection in utero.
yeah.
And if a pregnant woman doesn't understand that, it's like she's like, I'm not going to needle when I'm pregnant, that kind of thing. So at the master's level, our quote patient, if you will, is the bigger population at a whole. And at the doctoral level in nursing, it's about translating research to practice. Like, okay, at the master's level, we know that we want to contribute to making vaccines available and accessible and provide information to the community at large. At the DNP level, well, what are the problems and how do we do that? Someone might have done a study that, there might be research out there that says the biggest reason pregnant women don't get vaccines is they think it's unsafe to the baby.
Yeah.
So now we might develop a strategy, develop an educational program that's really doable and accessible and manageable to pregnant women. Or there might be another study that says, oh man, I don't know, I'm gonna vapor lock on a thing here. Oh, like maybe why does everybody with bronchitis want Z-Pak?
Yeah.
Why does everyone? Well, because there's this perception, well, green mucus equals bacteria, because a lot of people do think that green mucus equals bacteria. Okay, how can we educate that population? How can we dispel this myth?
Yeah.
I remember when I was working in the federally qualified health center one year, just in self-defense, I made a patient a handout sheet because everybody just kept coming back, in January, cough, green mucus. I'm like, it's not bacterial. You don't need an antibiotic. I promise you this will go away. Just go home and take plenty of fluids. I mean, I was nicer than that, but and then 2 weeks later, another appointment. I know you said this wasn't a bacteria, but it's green. And, on my blog, so and so said it was green. And I finally, out of self defense, I made a patient handout that would just give them, read this before So BSN, MSN, DNP, like the different levels of nursing, the higher level practice of nursing really expands the way we approach healthcare. And that's another difference. I mean, the APRN isn't just the diagnostician at the bedside, but we are also supposed to be leaders in our field. We're supposed to contribute to the health of the population at large. We're supposed to be educators, not just to patients, but to the RNs with whom we work, to our peers, even to other healthcare disciplines. We are consumers and implementers of research and evidence. Advanced practice is many facets. And
Yeah.
so that's like the bigger difference. But yeah, the one everybody like locks on is that the APRN is the diagnostician. So your next question is, well, how do you do that? Like if you're making that leap, if you're making that
Yeah.
difference, I swear that like the most important thing really is to have a good foundation in patho and pharm and physical assessment. And it's really different. Like in physical assessment in at the BSN level, at the bedside nursing level, we teach the head to toe, listen to the heart, listen to the
Mhm.
lungs, the belly, pretty much, here's what's normal and abnormal, we refer on. But at the level of the diagnostician, you really have to understand what's going wrong at in the physiology to produce the signs and symptoms. So if you do a physical examination and you appreciate that there is tenderness to palpation at the left lower quadrant, at the bedside level, you'd probably document tenderness to left lower quadrant, bowel sounds present or absent, notified MD or whatever, you
Yeah.
know. But at the advanced practice level, we have to recognize that if you palpate the abdomen and appreciate left lower quadrant tenderness, like one of your leading differentials is diverticulitis, or it could be constipation, or it could be ulcerative colitis, inflammatory bowel disease. You have to know why those conditions would cause that symptom.
Yeah.
It's the articulation of the pathophysiology and the physical assessment to help you figure out what's wrong with somebody. Like if a patient comes in and says, my stomach hurts, common complaint, my stomach hurts. Well, first, of course, the stomach isn't the abdomen. The stomach is up here and the abdomen is the whole thing. And it's about really zooming in on exactly what the patient is trying to say when they say my stomach hurts. Like first characterize, are we talking upper quadrant, lower quadrant? Is it bilateral or left or right? What does the pain feel like? When did it start? What are the associated symptoms? Is there nausea, vomiting? Is there constipation? Is there diarrhea? Is there blood in stool? Is there reflux? Is there a temperature? At the APRN level, you really have to be able to take a chief complaint, my stomach hurts, and right off the bat, the first thing any APRN should be thinking of is, okay, what are all the things that can cause a quote stomach hurt?
Yeah.
It could be gastroenteritis, diverticulitis, cholecystitis, hepatitis, pancreatitis, pick your itis. You start thinking of all these things, and then you have to understand the anatomy of where they are, the physiology of what kind of symptoms they would cause, because then the next step is to start asking the patient questions. The history of present illness is the next step in this process. And the history of present illness, every question you ask should be targeted on ruling in or out those causes. So if you come to me and say, my stomach hurts, and I start thinking of all these things that could do it, well, okay, my first question is where? Can you be more specific? Is it all over? Is it right upper quadrant, left upper quadrant, epigastric, periumbilical, lower quadrant? Because right away, if I say my stomach hurts and you say where, and I say, oh, right, and I point my right upper quadrant, like right under my rib cage, well, you can rule out diverticulitis, inflammatory bowel disease, gastritis. Like you can rule out a bunch of stuff right then, because what's in the right upper quadrant is the liver and the gallbladder. So then you're thinking, all right, I'm narrowing down here. Liver and gallbladder are most likely. What other questions do I need to ask? Well, what does the pain feel like? Are you vomiting? Are you nauseous? When did it start? And so every question in that history of present illness should focus on narrowing it down. And then you narrow down as much as you can. And then the next step is the physical examination. So whereas in, bedside nursing, we're taught to do the whole physical exam. You go in, you see your patient, you document HEENT, normocephalic, blah, 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 atraumatic, heart, lungs, whatever. But for the APRN, if the patient has abdominal pain, you don't go into all this head is normocephalic and atraumatic and nares are patent and the, eardrum is whatever. It's really about the physical examination that you need to do to support or refute all of the differentials that are left when you do a good history. So
That's
it's just very different. But patho, there's a reason, the three P's, it's a reason they're foundational courses. Patho, pharm, and physical assessment. a really good mastery of them is enormously important.
Yeah, that's a really good, that super clear, really good like summation of what that is to be like an
Hmm.
APRN. You know what I'm thinking as you're saying that though, like describing their role, I'm wondering, and this is a silly question, but if like RNs, for instance, the way we practice, we have different state practice acts, right? And
Hmm.
so it's a little bit different. Maybe my scope of practice as an RN and what I can and cannot do is different state by state. Is that similar, the same with an APRN, that the way you might practice and your responsibility is different from state to state as well?
Oh
Yeah.
yeah. In fact, it's probably worse at the APRN level. I
Mm.
mean, the registered nurse skill set, just because licensure is so uniform. I mean, if you move to another state as an RN, yes, you have to get a license there, but in every state you can do it by endorsement.
Yeah,
You know,
that's
you know,
true.
it's just by endorsement. If you're licensed in one state, you verify that and you can get licensed in another because the the scope of practice is so crystal clear. You know, the National Council of State Boards of Nursing has been in existence forever and they're very firm. And so, I mean, any nurse that starts practicing in a different state should absolutely read through the State Nurse Practice Act. But for the most part, the scope of practice from state to state for an RN will be very similar. There may be some subtle nuances with respect, you know, in terms of differences, but
Yeah.
it's really remarkably similar from state to state. But at the APRN level, it is not. It's very different from state to state, and it's really interesting. Like if you live on the border and maybe you practice in two different states,
Oh yeah.
you know, like, I mean, there's people like where I live, you know, here in Las Vegas, there are people that practice here and in California. Talk about difference. Or like further down, like in Laughlin, Nevada, or I get Laughlin. I feel like there's another town down there, but that's right across from Arizona.
Yeah.
So people will live in one state and practice in, you know, in both. Um, because sometimes the scope of practice from state to state is very different.
So really important.
Yeah. It is, and there's a lot of nuances. I mean, it's not just about if one state's a full practice authority or not. Even states that are full practice authorities sometimes have distinctly different requirements in terms of how many hours you have to have under your belt to be fully independent, you know,
Mm.
like prescribing Schedule II controlled substances. And then there's always questions about the procedures that you can do, which really vary from state to state. You know, in
Yeah.
some states, you can do some pretty heavy duty procedures. In other states, you can't. Um, Supervising other and ancillary healthcare providers, like in some states, you can supervise a medical assistant, and in some you can't. Um, it's in some states you can sign a DMV. You know, like if somebody's over a certain age, they might
Oh
have to
yeah.
have a signature to get their driver's license renewed. And in other
Really?
states you can't. Yeah. Oh yeah, there's a bunch of signing for home health. This was always a big deal, home health orders, because up until COVID, the Centers for Medicare and Medicaid Services, which you know really are the governing authority on Medicare, they did not accept an APRN signature for home health services.
Oh my
So if you
gosh.
wanted to order home health care and then order stuff that you needed for home health, like you know DME and stuff like that, Medicare, you had to have a physician sign it. But in individual states, some states would allow it and wouldn't. So like I was here in Nevada, I was I was the board consultant when Nevada enacted legislation that permitted APRNs to sign for home health and to order and authorize home health in Nevada. So in Nevada, we could do it. But if it was a patient on Medicare, we couldn't. Right. If you had local insurance and you know you had an accident or something, had to be on home health and needed some services and PT or whatever, an APRN could order it. But if you were on Medicare and needed home health, an APRN couldn't order it. And then when COVID happened, they had this temporary, I don't even know if we can still do it or not. Like for a while we were allowed to order it. But yeah, like whether or not you can order it within the state really does vary from state to state. And it's not the same as the federal.
And that variation, so now that's making me think about when you talked about too, like who you can supervise and who you can, and these different
Mm-hmm.
variations and rules. How does this play into like full practice, not full practice? I guess really my question is, how does APRN and physicians like collaborate in this way? Like if there's these big differences and roles, like autonomy and practice, like
Mhm.
where do those things meet?
There is, it's really interesting that I mean, I don't know every state law.
Yeah.
And while I know in Nevada, in like 99 out of 100 scenarios, an APRN that has more than 2,000 hours of collaborative C2 prescribing is then autonomous for almost everything. But every now and then, these little things come up where you need a signature and it has to be a physician.
Really?
And like sometimes it's like the DMV, it's not the nursing law or even the physician's law. It's the statute about motor vehicle authorization. If the statute says that a physician has to sign it,
Yeah.
then a physician has to sign it until somebody changes that law.
Love
Yeah.
it. Love it.
Oh, what a tangled web we weave.
Love
Yeah.
the politics about
Yep,
that.
yep, yep.
Well,
Yep.
let's get into something. So I'm curious. Like, I feel like I would struggle with fear, going from RN to APRN that, oh my gosh, I'm responsible for all of these things that I wasn't responsible for before. And I would just myself likely question every single thing. How did you adjust to that? Like going from RN to APRN and now it's you, pal. It's you. How did you do that?
I mean, I hate to say it quite this way, but ignorance is bliss. I was just so young and I really didn't fully understand and listen, it was over 30 years ago.
Yeah.
I just didn't have a full appreciation for the world of litigation and all that stuff. But I will tell you, I will never forget the first time it really slammed me in the face, the difference. Like, so you've probably heard me say this before. My first job as an APRN was in a hospital. I functioned like the resident, even though it's politically incorrect to say that. That's what I did. It was a teaching hospital, but they had a non-teaching service for geriatric patients and they could never get residents to stay on the service because it was boring, because residents were there to learn and do procedures and all this cool stuff, and many of the long-term care residents were DNRs. So while they would come in with things like PE and infection and MIs and all kinds of good stuff, but the care of them was conservative, comparatively speaking, you know?
Yeah.
So they finally hired me to be the house staff, the person that was there every day. You go in, make rounds, see the patient, look at the labs, make changes, try to get them out, try to get them fixed and get them out. That was my first job. And I was I like really ignorance is bliss. I was so oblivious to what the implications were. And I remember like I had one day of orientation with the PA who was leaving. And then I'm not making this up. I had one day, I started on a Monday and I rounded with the PA that had covered the service. She was leaving for another hospital to take a job in hematology, like across town. So I rounded with her all day. I just fought around writing notes all day. What do I do if this happens? What do I do if that happens? And then on Tuesday, I had to go to hospital, like fire and safety training, in the auditorium where you learn how to evacuate patients if there's a fire or whatever. And then on Wednesday morning, I was on my own and I did not have collaborating physicians in the hospital. My service, like the people that admitted to my service, were outpatient attendings. And so the patients would be admitted, and I was the one that had to admit them and go to the ER and do their physical and stuff and do their history and make a diagnosis and then prescribe treatments and transfer them to the floor. And then I was in house. I would get the call if they coded or if they whatever, if they spiked the temp, all the things you call the resident for, that's
Yeah.
what people would call me for. And so that first Wednesday, and I was just too young and inexperienced to even know. But that very first Wednesday on my own, I got called to the bedside of a patient that was in pulmonary edema. And she's in pulmonary edema. And as an ICU nurse, I don't know how many times I gave those patients Lasix when somebody else ordered it,
Yeah.
and I can remember standing there thinking, oh, come on, order the Lasix, grow a pair. Give me an order to hit this patient with some Lasix. And the intern be like, what do I do? And now all of a sudden, I'm the one that the nurses are looking to for the order for the Lasix. And all of a sudden I'm going like, wait, all those side effects I really didn't think much about, like ototoxicity and hypokalemia and all this kind of stuff. All of a sudden, it's totally on me. And I'm like kind of standing there hesitating on the Lasix, just like I had watched so many interns do before me.
Oh
That
my
was
God.
really that was the first, like, my first real introduction to the difference. And then, of course, it doesn't take long that you realize that's what IV fluid's for. Give them the Lasix. If you diurese them too much, give them fluids, give it K-Ride. I don't mean to sound cavalier because I really didn't feel that way. But yeah, that was my first. I was like, oh God, it's on me now. It's
Yeah.
on me to order this thing.
Yeah.
Um,
So
mhm.
no, I was just gonna say, so like how do you get through it? What advice would you give that like, oh wait, this is me? I'm stressed out about this.
I mean, you do. I mean, one thing on a lateral note, patients need for you to look confident, not
Mm,
cocky, not like you can't learn, not
mm,
like, not like you're God's gift to healthcare, but you do need to be confident. That goes a long way with patients. So even if you're not sure, even if internally you're bordering on bowel incontinence,
freaking
there
out.
really is a skill set in looking confident and telling the patient, look, we're going to take care of this. I got you. We're going to be fine. And as long as they're safe, even if you have no idea what's going on and no idea what to do, the first thing you do is make sure they are safe. As long as they're safe, you have time to figure it out. Don't get crazy and, like just don't get crazy and go off the hook. Once they're safe, take your time. So if somebody comes into you with abdominal pain and you have no idea what's going on, but their stomach hurts,
Yeah.
well, if they have bowel sounds and they're moving bowels and passing gas and they're not like there's no rebound tenderness,
Yeah.
because we are expected, coming out of school, rebound tenderness usually implies a surgical abdomen. But if my stomach really, really hurts, but I have bowel sounds, the patient's passing gas, I don't have a fever or don't have a significant fever, okay, they're safe. Now we can take a little time to figure out what it is. And then what you do then is get all the information you can. Remember that diagnostic reasoning process you were taught? And if you weren't taught it, come see us at FHEA. Because we can. This is, years ago, I used to teach assessment. That's exactly what I do. You got a chief complaint, my stomach hurts. And we write on the board all the things that could cause stomach pain. There's like 30 of them. How do we rule them out? One question rules out 10. Another appropriately developed question rules out another 5. You rule out as many as you can, and then you do your physical exam. And that's what you do if you're not sure. If you're not sure, make sure they're safe. Make sure the red flags are not present. If the red flag's present, it's easy. Off they go to an emergency room. But if they're safe, then you can take your time to figure it out. But look confident. Don't look like you're
Freak out, keep the freak out
don't look like you need it
inside.
depends.
Freak out inside, confidence on the
Mhm.
outside. You
Mhm.
know, so something I'm going to kind of go off on a tangent. So I'm thinking about the rules, right? COVID happened and everyone's world individually went nuts, right? But some APRNs that I knew were working as RNs. And I'm like, that's confusing. Like, first of all, I didn't know you could do that, right? If you keep licenses, I
Mhm.
guess you can. And like those two worlds kind of mix in a way. And I know there was a lot of different reasons for that, but
Mhm.
it made me curious about if you are an APRN and you continue to work as an RN, is there anything really important that we need to know about that?
Yeah. Yeah, there are actually. There's a few things. So the first thing to be sure of is that you are licensed as an RN, because not every state requires that an APRN be an RN in that state,
Oh, so you don't have to.
right? You don't have you used to, but now there are a number of states that will allow you to license as an APRN as long as you hold an active unencumbered RN license somewhere.
Mm-hmm.
So I think now, don't quote me on this because I could be wrong, but I'm pretty sure that Utah does not require an RN license in Utah to be licensed as an APRN in Utah, right?
Oh.
So you could be licensed as an RN in Nevada and an APRN in Nevada, and then want to practice as an APRN in Utah and just get your APRN license. If for whatever reason you want to practice as an RN, you have to make sure you're licensed as an RN. in that state.
Yeah.
So that's one thing. And I mean, people will overlook it. There
Yeah.
still remains this interesting level of confusion about the
Yeah.
two licenses. So first and foremost, if you're going to work as an RN, make sure you're licensed as an RN. Also, make sure you are covered by malpractice insurance
Mm.
as an RN. You know,
Not your
make sure
APRN's
that
not
you're
being covered.
covered. Make sure you're covered for the role that you are going to have. And I mean, those are just practical things, but really the biggest issue is not stepping out of your lane. If you're working as an RN and you're working as an RN, filling a job that has an RN job description, sometimes it's tempting to step out of your lane and make an APRN judgment call, and you can't do it. I mean, on a practical level, you won't be covered if you mess up. Like, and I mean something very basic. Like, say you're pulling in somewhere as an RN, you're working as an RN in med surge, and a patient, oh, we'll stick with this stomach pain because that's where we are, and
Yeah.
the patient tells you that they have abdominal discomfort or whatever, and you examine the patient, and you know it's probably diverticulitis. You know, if they were your patient in clinic, you would call it diverticulitis, but it might then just be tempting to say, oh, it's diverticulitis, here's what you do. We don't need to do anything else. We'll keep an eye on you. But you can't make a medical diagnosis under an RN license. So no can do. All you can do is do your nursing assessment and then notify the resident or, the attending if it's a non-teacher, whatever.
Yeah.
Notify the medical provider, and it's up to them to make the medical diagnosis.
If you had an RN license, just because you had an RN license before, and then got an APRN license, your license says that. Is
Mhm.
there a benefit in keeping both? Like, is there any benefit of just maintaining both licenses?
I mean, the only reason not to is because of the cost of renewing it.
Oh,
I
yeah.
mean, that would be the only reason not to do it because your CE, the CE that you have to do for your APRN will typically also apply to your RN. Like, it's
Yeah.
not like you have to do anything. And because an APRN is an advanced practice registered nurse, even though we're required to practice nursing to renew our RN license, your practice, it's an interesting dichotomy, but your practice as an APRN is nursing practice. So when you fill out your renewal application, even if you've only practiced as an APRN, when you renew your RN license and it says in the last 2 years, have you practiced,
Yeah.
as an RN, the answer is yes.
Okay.
So the only reason not to renew it would be if the cost was prohibitive, and I mean, the cost of an RN license usually isn't that
It's not
high.
too crazy. Yeah.
I wouldn't. I mean, listen, I keep every license insert I ever got just because I'm afraid to let them go. So I mean,
Oh,
I pay bazillion dollars every year for every RN, APRN, all my certs, and all that kind of stuff. Just because once you earn it, to let it go, you just never know when you're gonna, like, 5 years later, go, oh God, I wish I had this. Now that's a little bit different than if you have an RN license and you're an APRN, and then you go to another state and you just want to practice there as an APRN.
yeah.
I don't know that there's any reason to necessarily get an RN license in that state if the state does not require it.
Yeah.
But any license you already have, now it's just a matter of personal preference, but I'd hold on to it because it's a risk benefit analysis. The benefits are you worked for it, you earned it, it's there. And if you ever want to use it again, it's there. The only risk is you got to pay for it,
Right. So it's
you
not
know?
not like terrible to keep it,
Hmm.
just in case.
Right.
You
Right.
mentioned continuing education. So I think about, well, for my RN license, I got to do 24 every 2 years, like no big deal. But
Hmm.
working with NPs, it's like you guys have to do 18,000 every 5 minutes. Well, how is that different?
It is. I mean, it's different because first of almost all APRNs, excuse me, also hold a board certification.
Yeah.
That is not, remember in our last discussion, we were
Yes.
talking about cert versus licensure. So if you're certified by AAMP or ANCC, you have a CE requirement for them. And then your state board of nursing will also have a CE requirement. The good news, I guess, is that the requirement for the certifying boards is comparatively high. So as long as you maintain the CE for the certifying board, you'll have enough hours for your state
Oh, okay.
renewal. Except it's never
Oh.
easy, is it, Jan? It is never ever easy. Many states require very specific CE things with each renewal. That's not a like certification. Just for instance, the ANCC requires that every 5 years you have 75 hours of Category A continuing education in 5 years. So that's what, 15 a year? Wait, I have to do the math. That's hard. 15 times 5. Yeah. So 15 hours a year. Okay. And it could be anything that pertains to your role. But your state board of nursing might require that you have X amount of opioid prescribing, or X amount of cultural competency, or X amount of suicide prevention. Or like in Nevada, I swear we have so many requirements. Like, I don't know when we're supposed to actually do our specialty, because we have, I think there's some like geriatric requirement.
Oh,
Yeah, there's like an hour or two, or um there, I mean, I should know because I really like, I always like scramble at the last minute and go, oh God, I need this. But I know there's a cultural competency, there's an opioid thing, there's a risk, an opioid risk assessment thing, there's suicide prevention, every other licensure. So anyway, my point being that they're not necessarily always complementary either. So not only do you have to have more hours, but it's got to be at like some distinct percentage has to be at the APRN level.
yeah.
And I mean, it will meet your RN requirement, but it's got to be the APRN level for APRNs. And then you have to look for the states. Like I know Florida has a requirement, I believe, for human trafficking.
For RNs, for sure. I know
Yeah,
that. Yep.
yeah. And domestic violence.
Yep. And like
Um,
the states and laws or the
yeah,
local
yeah.
stuff. Yep.
And then Pennsylvania has a very specific requirement about child abuse and neglect.
So this is
So,
another good point about knowing your state practice act, right?
hmm
What is really
hmm
required of you, 'cause it's going to be a
yeah,
little bit different.
yep,
And that's a
yep.
lot. Like, when you first had that transition, or even when you maybe were working with like students or people that transitioned, like what's the advice that you gave about you're going to need to connect or network or a mentor? Like, surely it's not like, goodbye, good luck, you're on your own.
No, I mean, I don't like, I see students fairly early in their curriculum,
Yeah.
and then I don't see them again. So I mean, I do like, I teach pharmacology, so I'm always very very proactive to make sure they understand
Yeah.
about pharmacology requirements, and the whole DEA thing and the opioid
Yeah.
prescribing and stuff like that. But honestly, I don't know. I don't know. I hear from a lot of students, like in our review program, that tell me that they were never taught anything about that kind of stuff,
Oh, wow.
which is worrisome. Yeah.
Yeah.
We should do a transition to practice
I
program
mean, honestly, what I mean,
that
and with
is
that
that.
said, like if that's true, if I'm a student who's coming out and I'm like, I don't know, like what's the advice that you would give me? Like I feel like I'm alone and I'm transitioning into this new role and I'm just not
And
quite certain about I need some help.
I mean, there is a package of stuff. There is certainly like certification and licensure and your
Yeah.
responsibilities and how to go about them.
Yeah.
Malpractice insurance,
Yeah.
the different types, and making sure that your practice is covered. Um, DEA registry. Um, I mean that whole thing. But also, oh man, that fast there was something I had and I lost it. I'm having like mini TIAs or something. Mm.
It'll come back to you.
Probably at 2 a.m. So I mean, certainly the difference between, practicing as an RN and practicing an APRN, like some people really don't know that it's not just what you're licensed to do, but what are the confines of your role description,
Yeah.
And I also, you really want to understand your role description at your organization. Like just because your APRN state license allows you to do certain things, your organization may not.
Yeah.
And if your role description prohibits something and you do it anyway because you don't know, and then you find yourself being sued, chances are your malpractice won't cover it. Oh, I know what it was. I know what I was going to say. Another thing that happens is that when people first come out of school, they, not being sure what's going on, they will like take the word of the physician as law
Mm,
and Just don't do, like an example I'm thinking of, when I was the APRN investigator with the Nevada board, it is against the law in Nevada to use pre-signed prescription pads. It is specifically prohibited by the law. An APRN can't use a physician pre-signed prescription pad. I mean, I don't know that I think it's a great law, but that is the law. You know, you can't do it. So a lot of APRNs, when they first graduate and they're waiting to get their boards done and stuff, they can practice under a graduate license, but they cannot prescribe. So they can start in their first job, and they can start, like start medical decision making, see the patient, evaluate the complaint, work through the whole thing we are just talking about. But if that patient needs a prescription, the physician or somebody else there, like a fully licensed APRN, has to give the prescription. But many times, I mean, I've saw it more than once, it's just a physician hiring the APRN, and they don't have time, they don't want to go in the room, and they just like sign off pads and tell the APRN to use it. And the APRN thinks it's okay because the physician told him to.
Yeah.
And it's not. And that's not an excuse. I mean, that's not considered a valid reason for doing that. So if you find yourself being disciplined before the board, or being investigated by the board and having to answer to it, the fact that a physician said it was okay isn't an acceptable answer. Because one of the other things that we have to remember is that when you accept a license that's issued by a state, that license confers certain privileges.
Mhm.
And your responsibility as a licensee is to know the law that governs your practice, and to know what you can do and what you can't do. And I didn't know, or somebody else told me different, isn't isn't an
That's not
answer. I remember there was I felt so badly for this new NP, young guy. He was a new NP out in very rural part of the state, and was hired by a physician who had been around for 100 years, and was like, like the Percocet guy for everybody in the surrounding area. Now, there was a time when a lot of old farmers and stuff, out in that environment, really bad arthritis and back pain. It was very common to have them on Lortab and Norco, and that's just the way it was. These are people that didn't have access to physical therapy and steroid injections and things
Yeah.
like that. When you live out in the middle of nowhere in a community of 500, we gave him Norco to get him through the day. Um, and so, but this particular physician was very heavy-handed, and it was the peak time of the opioid crisis, and the FBI actually developed a case against this physician. And the NP was a new NP right out of school, working for this guy, and just mimicked what he did,
Yeah.
and didn't know any better. And I actually lobbied very hard. I mean, he was very cooperative. The FBI shut down, the FBI and the DEA working together, they
Ah,
shut down the practice. And I don't know where the physician went, but the poor MP, like he went back home to a different state, but he was very cooperative with the investigation, and he was like devastated. He was destroyed. And I remember lobbying very hard for him not to be disciplined in like a severe way that would impact the rest of his career, even though to the letter of the law, when you accept that license and you start practicing under that license, it's your responsibility to know what is and is not permitted by that license. But we just don't do we as a discipline don't do the greatest job of educating our new grads about stuff like that. Yeah, we need
no,
a we need a transition to practice
I know.
CEO.
I saw Teresa drop that in. I said, yes, too. We hear you loud and clear. And it's
Yeah.
funny because this story too, and then we'll go ahead and read out some of these
Hmm.
questions, comments we have. I wonder, it's kind of like this unspoken thing, as you're saying this, Sally, of like, oh, I hate to say it, but it's like as nurses, right? Sometimes we get so, as RNs, we get so wrapped up in following whatever the physician says, whatever the
Hmm.
physician says. And that's kind of like
Hmm.
a culture thing that
Yep.
I imagine in some ways is a little bit of a struggle to shake off
It
and
is. It
recognize,
is.
like, no, no,
Hmm.
no, it's no longer that. You're in charge. You're in charge
Hmm.
of this. Yeah.
Hmm. You are. You're in charge of your own thought process, and it is hard to shake off. I mean, it's a very paternalistic relationship,
Yes.
and I don't mean gender, male female physicians versus male female nurses. It is a very paternalistic hierarchical relationship, and when you become an APRN, you've got to shake that. You got to learn to shake it. And I know it's easier said than done. I know. In fact, I'll give you a real quick story. and then we'll go
Yeah.
to questions. Okay. In that first job I was telling you about, give the Lasix, and I'm like,
Yes.
Lasix. It didn't take long. It didn't take long, and I was very fortunate. I mean, this was over 30 years ago. But I was like, that was the first MP the facility ever had. They weren't. They really treated me. The physicians, for the most part, treated me like a peer.
Mm.
But like maybe 6 months into that job, I was feeling more confident, not cocky. Even now, even today, never cocky about medicine, because it's, every time you start to think you know what you're doing, some patient comes along and like disabuses you of that notion. But I was just starting to feel I had good mentors there. I had learned a lot and I felt really good. Anyway, I got called to the ER to admit a patient who they said was presenting with abdominal pain. So the ER doc told me that the patient had abdominal pain and he thought she was having a mesenteric artery infarct, but they were admitting her to my service. So I had to go do the admission, but he had already called the surgical consult.
Okay.
So surgery was coming down. Like that's the way it is. A patient's admitted under a certain primary service, and then whatever consults you need, you consult, and the consultant manages that aspect of care. But it's my service, my patient, so I go down. So I go down, and this ER doc did not like me, did not like MPs, didn't like the whole concept. He was a real jerk. He's like one of the few in that facility. He's really jerky. His name was Jack. I forget his last name, but he's probably retired now. Anyway, yeah, Jack didn't like me. So I go down and he's like, they told me I had abdominal pain, right? So the patient's in this little, cubicle area. So I go back in. It's this older woman from the long-term care facility, but she was very with it, awake, alert, oriented, whatever. She was pale, she was diaphoretic, and it was not abdominal pain. It was substernal chest pain. She was on 100% non-rebreather mask, and her O2, like her PaO2 on a blood gas was like 80 something. This lady was a textbook pulmonary embolus. If you looked up pulmonary embolus in the dictionary, there would have been a picture of her there,
Wow.
in her pale, cold, clammy. I was absolutely certain this was a pulmonary embolus. Now, while I'm down there at the bedside, the surgeon comes down, and he was a very tall, intimidating, his name was Dan. Dan, the intimidating surgeon. And he was like a man of few words, didn't say much. Not really sure what I was doing there. He comes in, he like looks at her for a minute, like didn't really say much, whatever. He goes back out to the desk while I'm still in the room. So I go out of the room to the desk in the ER. So here's Jack, the jerky ER doc, and Dan, the intimidating surgeon. They have both decided she has a mesenteric artery infarct. And I'm like, no, I just knew. Thank God. I mean, thank God I knew. I was like, no, I think she has a pulmonary embolus. And the ER doc's like, well, pulmonary embolus doesn't give you abdominal pain. And I said, she doesn't have abdominal pain. She has chest pain. She's pale. She's clammy, and she's hypoxic, even on 100% non-rebreather. I want her to have a VQ scan. This is like an episode of House. Like this
Yeah.
was back then. VQ scan was the
Yeah.
diagnostic study. This was before spiral CT. So VQ scan for PE, but she needed an arteriogram for the if it was a mesenteric
Yes.
artery infarct. This is like an episode of House. One will kill her, one will cure, And I was like, no, she's my patient. She's going to VQ scan. And if the VQ scan is negative, you can do your arteriogram.
You're saying.
And I mean, the ER doctor's like, you're going to kill her, Jesus Christ. And he's throwing stuff around. Oh God, you're going to kill this patient. The surgeon just sort of like looked, didn't roll his eyes, but he just sort of made a look and walked away quietly. And off she goes to VQ scan. I swear it was a Friday afternoon. I couldn't write this stuff for a book. It was a Friday afternoon. So like I go back, I call my attending. I'm like, look, you're going to hear about this, I'm sure. Everybody's mad. I think she has He's like, God bless him. He said, Sally, I trust you. If you think she has a PE, he's like, but call pulmonary, let him know. So I called the pulmonary consultant we always use. I called Paul. He's like, oh, Sally, I don't know. If Dan thinks it's a mesenteric artery, I was like, no, it is a PE, and she's a PE, and we're going to consult you. And then when the moonlighter came in, who was a physician, resident physician who was moonlighting
Yeah.
there, I'm telling him, he's like, I don't know, Sally, if they think it's a PE or if they think it's a mesenteric artery. I'm like, no, it's a PE. So then I go home. I go home contemplating the end of my career. Can I get a job at Fridays, whatever. And then the next day was Saturday. I was off, but I had a nose. So I sneaked back I like sneaked up to the floor and I look at her chart. The whole right lung was occluded with this massive embolus. I was so
Oh,
happy. I mean,
wow.
she was alive, mind you. She was still alive. But yes, she had a PE. The surgical note was like something like right pulmonary embolus will sign off. And then
Ah,
I actually turned out to be very I worked very closely and very well with that surgeon for the rest of my time there, who had a lot of respect for me
I see,
after
look at
that one.
that.
I don't
Look
know
at
what happened to Jack, but like that's what you got to do. You can't just be like, no, and it's believe me, easier said than done. Like even in the ER that day, the nurses were all like backing up from the table, like pushing their little wheelie chairs far away because nobody wanted to be even in physical proximity to me when Jack was going off about how I'm going to kill the patient and how stupid and all this kind of stuff. And Dan was just sort of looking disapprovingly. The nurses all backed away, the chairs all disappeared. um, but uh, you know, you got to do. Yeah, I mean, that's what you have to
have
do.
to.
It's your license and your patient. Yeah,
Hey,
it's hard. It's
it's
hard sometimes. I mean, now it's not. Now, geez, do if I had a nickel for every physician I saw make a mistake, and NPs make mistakes too, believe me. But these, a good physician is awesome, but not everybody's good, and not all good people are always right. And if you disagree with what another MP or a provider. Now, if you're not sure and you're new and you're learning, okay, that's one thing. But if you are really confident in your diagnosis and somebody else disagrees with you, if it's your patient, you do what you think is right. And if you're consulting for them, well, you just give your opinion and they'll do what they're going to do with it.
that's a great lesson. Dr.
Mm,
Miller stood on
I,
business.
I did. I did. I
That's
mean, I think I might have
great.
crapped myself that day, but
Good for you. That's a great lesson. All right, let's pop over here and see what we got. Teresa shared that after you're licensed as a Florida APRN, you can drop your RN license. Yeah, that's true. And then we heard
mm-hmm,
some good reasons why you might want to keep it.
mm-hmm.
Is anyone else completely frustrated with being offered less than RN money and compensation, but zero onboarding and ramp up to adjust to the dynamic surviving the logistics of managing a visit? Yeah, I hear things like, and this is obviously not at all a good reason to be an APRN, but like I can go from RN to APRN and make a ton of money. But I feel like that's not always the case.
No, you can't, and appropriately so. I mean, you're an experienced RN, you're a novice APRN.
Yeah.
You're probably not going to make as much money. And then factor in all those other things like the big bucks are like locums work or, pool work and nights and weekends. Yeah, you can definitely make more in many settings as an RN. As an APRN, you're generating revenue. Like you have to support yourself. You have to bring in enough money to pay you and pay the staff and the office and the insurance and all that kind of stuff. Like you're revenue generating. And in the beginning, you're probably not revenue generating. Like when you see what those insurance companies pay for your services, like it won't buy your lunch half the time. You've really got to be able to either do some heavy duty stuff that generates higher fee codes or work in volume. And in the beginning, you can't. So like, will you make as much right off the bat? Probably not. But the potential is exponential. You will top out as an RN. There's a point beyond which you cannot go, and you are always at the mercy of the market. There's just a lot of downsides to all this cash that you maybe could bring in right now. As an APRN, though, you do have to learn the logistics. You do have to learn how to get through a visit, get through like the charting process. It's a learning curve, and like any new job, don't expect to make as much going in. I think it always kind of shocks me, like when I hear my students have these expectations of making all this money upon graduation, while simultaneously expect to be given like an hour for every visit.
Yeah.
I mean, it just doesn't sustain. It is not sustainable. So in the beginning, you won't make as much. If you want that training time and you want to have more time to learn how to navigate the logistics of a visit, you're just not generating that much money and shouldn't expect to make that much. But where you can go, when you get a strong skill set, then you can negotiate. Really, there's no end to what you can negotiate. Whereas as an RN, there's really not much in the way of negotiating as an RN. There's a scale, and the best you can do is get at the top of it if you're
Yeah.
lucky.
Yeah.
Yeah.
Right. Deborah says, has anyone heard of APRNs not being able to call a medical assistant an MA? Well, that's interesting. I was told
Mm-hmm.
that the MA title is for physicians or PAs to use for their assistants only. APRNs have to call their assistant by another name. We are using clinical assistant in our office as I own my own practice as an autonomous APRN. That's interesting.
Does that person from Nevada by any chance?
That's Deborah. Let's see if she's from Nevada. Drop us in
So
and see.
here's, I can tell you that was a big deal here in Nevada a few years back. There was this whole big thing about medical assistants are part of the, oh, in Florida.
Pensacola.
Okay. Um, I can't speak to your state, but I would dissect that law. And I know we're running really close on time here, but maybe we'll close out with this.
Yeah.
In Nevada, there was this myth perpetuated. I mean, it was accepted as a rule that an NP could not delegate to a medical assistant because medical assistant was in the language of the physician law, and that a medical assistant under our law was essentially considered an extension of the physician. So
Oh,
the physician delegated. The nursing law doesn't speak to an MA at all. So forever and ever, the Nevada board was telling NPs that they could not delegate to a medical assistant. But but then when yours truly took that role, and we had a complaint where just an ancillary finding was that the NP was using a medical assistant. And even the board attorneys were like, you can't do that. When we drug out that law, there are two key features here. Number one, at least in our state, you have to check on your own. A medical assistant is not certified or licensed by any board at all. It's
hmm,
not required, right? Certified nursing assistants are certified by the Board of Nursing, but a medical assistant is not certified by anybody. So there's no legal authority to use that term. Anybody, any job could be called a medical assistant if you want to.
yeah.
So 100% a nurse practitioner can hire a medical assistant and call that a medical assistant and delegate to it. Because when you pull out the nursing law, a nurse, it doesn't distinguish nurse versus APRN, but any nurse can delegate to someone who they feel is experientially or by training, experience, or something else, education, training, or experience, qualified to perform the task that is delegated. So, as a nurse, I can delegate giving an injection. I
Hmm,
can delegate changing a dressing. I
hmm,
can delegate all the things that I would delegate to an MA as long as I am confident that that person is qualified to do it. Now, if it goes wrong, it's my license
yeah.
answerable because he or she is basically functioning under my license. But yeah, it was a myth, and we finally reversed that position and stopped saying that because medical assistant is not a protected title. Anybody in this state can call themselves a medical assistant, and if I, as a nurse, feel qualified to delegate to that, like I feel that person is qualified, if they happen to be a medical assistant, no problem. So yeah, it's a bit of a
Fun.
myth there.
Yeah, that's a wacky thing. And I'll have to check
It
that too,
is.
'cause I'm in Florida.
There's a
Awesome.
zillion wacky things in our world.
Yeah. Thank you
Mhm.
for that, Dr. Miller. And thank you all for joining us and listening in. The great questions, great feedback here. Transition to practice. We heard that loud and clear. We'll take that back with us as an action item. But thank you all for joining. Val, thank you. We hope you enjoyed this. Hope you enjoy these. We'll do definitely a lot more of this. And then happy holidays. I got to remember to say
Happy
that. We are so deep in
holidays.
December. Happy holidays,
Happy
everybody.
holidays. Happy New Year. See you next
Absolutely.
time.
See you next
Bye
time.
bye.
Bye.
Happy holidays.
Now we're going to break out in song.